Okay, good evening once again, everyone. At the outset, let us thank All India Ophthalmic Society for giving us the platform, though virtually, to organize this course, which will be primarily dealing with overcoming the challenges in combining surgeries, mostly phacoemulsification with different ophthalmic conditions, right from anterior segment to posterior segment. We welcome you all and also welcome Dr. Gajendra Chawla sir from Bhopal to chair this session as well alongside with me. Let's start with the first talk with none other than Dr. Purendra Bhasin. He doesn't need any introduction. He is an international faculty for all the various ophthalmic conferences, and he will be talking to us on optimizing outcome in coexisting cataract and corneal problems. Can we have the talk of Dr. Purendra Bhasin, please?
Yeah, thank you, Dr. Manoj, and I'm really overwhelmed that we are going to discuss on cataract surgery along with coexisting pathologies. And I thank all the speakers over here and would wishes post-COVID. We are meeting in a virtual, for the first time on a virtual platform during AIOS. Can you see my screen, please?
Yes.
Yeah. So my talk has been optimizing outcome in coexisting cataract and corneal problems. I have no financial interest, and I am really thankful and obliged to Dr. Manoj for giving me this opportunity. Yeah. So the question is, why should we look for the conditions wherein we have to look at the ocular surface? This is because we come across with unhappy patients post cataract and IOL surgery. Nowadays, we know that IOL surgery is more a refractive surgery. And more so, the patients are unhappy because when they are spending more, they expect more. So they don't want to have problems post-cataract surgery. They want that everything should be uneventful, and like what they were at 20, 30 years of age, they should be able to see that vision. So, and really we can impart them too if we are very careful. So this is what is the course and this talk upon. Blurring of vision at distance and near could be due to the residual refractive error. And this could be due to the inaccurate IOL power calculation. And this inaccurate IOL power calculation could be the resultant of the unhappy, the corneal problems, Meibomian gland problems, and problems related to the calculation of the IOL power. Now, somebody has not taken it seriously. And all these things will, everything will come and it will land on the unhappy IOL patient in our OPD and in the waiting area, which we don't want. Patient if complaints of fluctuating vision, especially when reading, this could be due to dry eye. Glare and halo mainly due to related to the IOL, but could be due to dry eye as well. And there is a decreased contrast sensitivity, which is exacerbated by the ocular surface disorders. Ocular surface conditions like lid abnormalities, the presence of entropion, ectropion, and Meibomian gland problems, and corneal degenerations could be present like Salzmann and pterygium, Salzmann nodule and pterygium, or maybe spheroidal degeneration. Patient can have dry eye, blepharitis, Meibomian gland disorders, anterior corneal dystrophies like epithelial basement membrane dystrophy, and corneal ectatic disorders, mainly astigmatism, which has not been taken care of. Coming to the dry eye, cataract surgery can exacerbate dry eye because of the use of topical medications post-operative period, because they have the preservatives and frequent use is suggested. Then corneal incisions, they can lead to they can damage the nerves, and they can also induce the dry eye. And the eye post-surgery is in a pro-inflammatory post-operative status. So due to this, there is a propensity for the development of dry eye. There are the potential problems are inaccurate IOL power calculation, and there is a leading to the residual refractive error. So if the patient's dry eye condition is pre-operative and which has been missed, it can lead to inaccurate IOL power calculation, and this can ultimately land into patient into residual refractive error. Then there is a blurred vision, fluctuating vision, glare or halo, and decreased contrast sensitivity, which could be there due to dry eye. So the pre-operative identification of dry eye is very important. And if we are taking the patient for the premium surgery like multifocal, trifocal IOL or a toric IOL, then we should always treat these cases first, and then after normalizing the surface, then we should plan for the surgery. And for this, we should take the history of any systemic disease, any medication, and we should examine the patient thoroughly, do topography. As you can see, the topography tells us the Myers which are irregular in this case, in this particular case, and we should alarm us that this is not the right candidate for the multifocal IOL. And fluorescein lecement green or rose Bengal green staining will help us in guiding us in presence of the dry eye. Role of diagnostic testing like tear osmolarity and MMP9 are also available, and which will guide us to how to treat further. Treatment is using the preservative-free artificial tear, warm compresses, omega-3 fatty acids systemically, topical cyclosporin 0.05% or Xiidra or Liftigrast can be added to the pre-operative treatment. Low potency topical steroid also is very helpful. Use of punctal plugs, autologous serum. It all depends after the evaluating the patient on slit lamp examination and in dry eye clinic, then we can treat these patients accordingly. And these are the condition of Meibomian gland dysfunction. A lot of fatty discharge is there, which coats the surface. Manage them beforehand using the eyelid scrub and warm compresses. Use topical antibiotics, azithromycin, 1%, low potency topical steroids, omega-3 supplements, oral doxycycline, minoxidil, or azithromycin. Maybe we can give it 3 weeks prior to the surface. Coming to the epithelial basement dystrophy, which are very subtle, but it can be missed by a general ophthalmologist or early young ophthalmologist. Most common anterior corneal, this is the most common anterior corneal dystrophy. Map-like changes seen in most patients. There is a negative staining with fluorescein, vision affected by irregular astigmatism and scarring, and can get worse after the IOL implantation. Key is to see it and tell the patient about it before surgery, and maybe if the OCT topography is seen, then this is the dystrophy on OCT, anterior segment OCT, which we can see, and this is the patient after laser treatment of this the post-treatment epithelial basement dystrophy is been disappeared. So we did surface laser treatment for this. Another condition is Salzmann nodular degeneration. As you can see here, there is a single nodule, and on the bottom picture there are confluent nodules which are present on the almost covering half of the cornea. And we all know that they induce very high astigmatism. They are gray-white elevated nodular lesion, usually in the mid-periphery or periphery. They are not present in the pupillary area mostly. The more common in females. No clear etiology can be associated with MGD and ocular surface inflammation, although often there is no associated disease, and it causes great amount of irregular astigmatism. So this is the topography Placido disc before, and after the treatment, after scraping the nodule, you see that cornea has become, irregularity of the cornea has disappeared. Coming to another common problem, which is pterygium, which we commonly see. And if you manage the pterygium beforehand, remove it, do the surgery, and after 1 to 3 months post-surgery, you can after removing the pterygium, you can perform the surgery. This is the image of Placido and Placido disc image of the with the patient's irregular mass, and it causes irregular astigmatism on topography. And even a subtle pterygium like this at the bottom can induce astigmatism, like you can see the change in the irregularity of the Meyer. This is a very interesting case. We did a multifocal IOL for this patient in one eye. Later on, she came for the other eye, and we found that the patient is having pterygium. And this, due to this pterygium, the patient has induced astigmatism with the rule astigmatism of 1.52 diopters at steep meridian at 69 degree. So after this, we did pterygium surgery, and after the pterygium surgery was done, and after 3 months of the pterygium surgery, or rather 4 months of the pterygium surgery, the astigmatism came down to 0.5 diopter. So such patients, as you can see here, this is the area of pterygium, and this is the multifocal IOL which we have implanted. The patient is happy after that. So if pre-operative assessment is done correctly and explained to the patient really understand it. And then comes the corneal opacity. This is the patient with adherent glaucoma. And most of these cases, we have a good amount of clear corneal with us, through which we can do the phacoemulsification surgery. The trick is that capsular axis should remain continuous under the area of opacity. We should not leave the leading edge or the edge with which we are holding the capsular axis. And a phacoemulsification is done. You will see that I'm pulling the nucleus in the area where the clear cornea is available to us, through which we can do the phacosurgery. Our excursion or the movement of phacoemulsification should be small enough. We should not go to the periphery. So this is how we can perform the surgery, even in the presence of corneal opacity. Now, one case I will show you that in this particular case, the cornea was hazy and diffuse haze central was there. So we used retrochandelier illumination, and this is how we can we are able to see. The good part is that we get a very good reflex, because the illumination is from the hand side, from the vitreous side, and we got very good red reflex, which otherwise would have been impossible. And it helps us, it guides us in doing a capsular axis and phacoemulsification. We just have to get oriented to the depth perception in this particular, when we are using retroillumination instead of microscope anterior illumination. And this is a chandelier, so the whole globe shines from behind. And thanks to Dr. Dhananjay Shukla for giving me this chandelier illumination system for this surgery. And thereafter, I am using it regularly in cases of corneal opacity and cataract, and it makes my life very, very comfortable and easy. And I feel it to be very, very safe in performing it. Otherwise, it becomes very difficult to perform the surgery when you have a central diffuse corneal haze or corneal opacity. So, take-home message is, look for ocular surface pathology carefully, pre-operatively in all cataract patients, more so in premium IOL patients. Ocular surface disease is often the source of symptoms in our unhappy post-operative patients. And corneal topography and Placido rings can provide valuable information before taking the patient for surgery. Optimizing the ocular surface before, during, and after surgery may give surgeons the best chance at providing patients with the wow effect. With proper diligence and care, one can successfully perform phaco in cases of corneal opacity. Fortunately, in majority of cases, there is enough clear cornea to perform phaco. Visual outcome in these cases are less than optimal, which we have to explain to our patients beforehand, and we should take informed consent. Patients gain enough vision to enable them to carry out their daily activities. One should be prepared to convert to ECC or SICS as per the choice. Thank you. उसको करना share screen.
Thank you, sir, for an excellent presentation as always. It's a pleasure learning to listening to you. Just a small query I have. You are using that chandelier illumination. Don't
Yes.
you feel we are not vitrectomizing this eye and it causes undue vitreous plug there or some kind of vitreous disturbances in long run? Have you encountered any problem due to that?
No, I have a small experience of small number of cases. By now, I have done only, I think, 13, 14 cases only. But in all these cases, I have not come across, maybe because of the patient's age, which are elderly age group, and by the time the fluid is vitreous is fluid-like, probably. But I have not come across with this. But this has been reported, this kind of system has been reported in the literature also. Some people are using this.
Yeah, totally agree with you. Even when you have hypermature intumescent cataracts, even with the cornea clear, a lot of people tend to use this kind of maneuver in spite just do a kind of a stab entry there. But brilliant presentation. Any questions or comments from the panelists or audience?
I think since he has used that small gauge 25 gauge, the risk is little less as compared to the previous one. What we were using 20 gauge or 23 gauge. So these probably is a little safer option.
Yes, sir. Good suggestion. We can use 25 gauges.
Can I
Yes,
add,
sir.
Manoj?
Yes, sir. Please.
Virendra, it was really a wonderful talk. I think it's very important for everybody to know that the ocular surface, because many of us neglect the ocular surface and go ahead and doing a cataract surgery, completely forgetting the fact that the ocular surface is completely screwed up in this patient, either because the drops are preoperatively or not recognized it. And that is the reason for the unhappy patient. Many of the problems occur, and you have nailed the this thing correctly, and you have given all the points. Very important to optimize the ocular surface before you venture into cataract surgery. Don't be in a hurry to do, because ocular surface is very, very important aspect of the clarity of the cornea, as well as the optical quality of the lenses, intraocular lenses of the cataract surgery as well. The chandelier illumination, I have also used it, and it's a 25 gauge. It's not a problem at all. And otherwise, you can put the chandelier illumination into the anterior chamber also, or you can ask the assistant to hold the endo illuminator. Only thing is, the assistant holding the endo illuminator is because it's a chandelier. If you put a chandelier, it's fixed. Sometimes the assistants keep shaking the thing. You can use the endo illuminator. I've done that also. The most important aspect is the capsular axis. If you're able to get the capsular axis right, and otherwise you can tilt the eyeball and do the phaco. That's not a problem at all, because when you're doing the phaco, when you're doing the capsular axis, you need a fairly good red glow. For that, the chandelier or the endo illuminator works wonderfully well as well. And doing the phaco, what I do is, if the opacity is a little eccentric, then I tilt the globe using the side port to the second instrument. I tilt the globe according to that, so that or sometimes I tilt the microscope also, so that it goes through the fairly clear cornea before we when we do the phacoemulsification. So these are some of the points which you can learn, but you have covered it so very well, Purendra. Thanks a lot.
Thank you.
I know you do a lot of trauma cases.
No, these are routine cases, and we have to manage them beforehand.
I have seen your wonderful videos on traumatic cataracts and with the corneal opacity, corneal tears. I've seen that, and that's the reason why I'm mentioning that.
Thank you, sir. Thank you.
Dr.
Thank
Manoj,
you, sir.
Can I add something?
Yes, Piyush, please.
First of all, excellent talk by Dr. Bhasin sir. Fantastic points that were brought out. And I agree with what Dr. Mohan Rajan sir has just brought about, saying that 25 page using a 25 page chandelier illumination does not have any problems. I don't have too many cases, but roughly somewhere around 30 cases or so, and where we had used chandelier illumination patients who had traumatic cataracts, and patients who had corneal opacities, and sometimes we did combined surgeries for them as well. So in patients who had just an isolated cataract surgery, post cataract surgery, what we also did was just have the question that Dr. Manoj had put up, whether does it cause any problems and retinal surface problems. So far in all the patients that did have purely cataract surgery with chandelier illumination put inside. Using an indirect, we checked post-surgery, and there were absolutely no problems whatsoever. Along with all the retina colleagues who use chandelier illumination as an adjunct in such situations, it's been quite safe so far. Not many problems have no problems have been reported.
Thank you, Piyush, for the wonderful comments. As always, next we invite Dr. Vinita, another doyen in inter-segment surgery. She will be talking to us for phacoemulsification with trabeculectomy in difficult situations and how to tackle these combined surgeries. Dr. Vinita, please.
Yes, sir. I'm sharing my screen. Just
Yes,
a minute.
madam. Yes, please.
Is my screen visible?
No,
Not yet, madam.
Not yet, Vinita.
Now it's visible.
Yeah.
Yes, madam.
Yes.
Please go ahead.
So at the outset, I would like to thank AIOC and Dr. Manoj Khatri and Dr. Gajendra Chawla for giving me this opportunity. And I will be talking about phacoemulsification and trabeculectomy, a combined surgery. A combined phacotrabeculectomy is like a double battle with a single weapon to manage a coexisting glaucoma and cataract, which is very common in elderly people we come across. But there are a lot of challenges doing this combined phacotrabeculectomy. These challenges is often due to the diagnosis and treatment because both can influence the management of each other. The factors which can decide the management plan for coexisting glaucoma and cataract would be a stage of cataract, the level of intraocular pressure and target IOP, type, severity, and rate of progression of glaucoma, associated comorbidities, the patient's preference and affordability, and the surgeon's skill. When we formulate the management, we can do cataract surgery alone, we can do a combined surgery through single site or a twin site, or we can do a two-staged surgeries. I prefer the technique of combined phacotrabeculectomy because it shows a good results, which we will be discussing soon. And I will be giving you a road to the success for combined single site phacotrabeculectomy by providing the pearls in the form of a preoperative evaluation, their indications, surgical technique, postoperative management, and advantage. The effective management, the key is a proper preoperative comprehensive evaluation. So once we evaluate a cataract, for which we are more accustomed is the type and location of cataract, the density of cataract, but we are more worried about the pupillary dilatation, the integrity of zonules, the presence of pseudo-exfoliation and anterior chamber depth, which are the common associate when you are tackling a combined glaucoma and cataract patients, and maybe sometime micro-ophthalmos or nano-ophthalmos. Glaucoma, as usual, we need to check for intraocular pressure with applanation and target IOP, definitely the angle to find out the cause of glaucoma, the optic nerve status, the fields, the type of glaucoma, severity of glaucoma. So after that, we have to have a preoperative detailed documentation to the patient, and we should get a proper informed consent with a realistic expectations, because these patients, they need a regular follow-up for glaucoma even after the surgery in post-op. Second pearl would be properly choosing your cases. The single site phacotrabeculectomy is to be done in patients, those who are having an uncontrolled intraocular pressure with the maximum medical therapy and visually significant cataract. It could be with an advanced optic atrophy where the postoperative IOP spikes during cataract surgery will be lethal. And second could be a very severe glaucoma associated with a cataract where you need an urgent visual recovery, and those patients, those who doesn't want to continue medical management because of the allergy, compliance, economical or various other issues. Second will be pearls of doing the surgery. It can be done in any way a surgeon is accustomed to. I do a surgery with 15 number, after making a Phonics blaze flap, I do a 15 number blade and triangular flap, and do a phaco through that tunnel, and the phaco will be a routine phaco. Only thing is just to look for the pupillary dilatation, look for the dense cataract and the shallow anterior chamber to be taken care of. So nothing to show in a phaco. So the phaco and the implantation of the intraocular lens will be exactly the same. What is more important is cutting the inner window, which is 2.5 into 1.5, and taking the pigment behind that. Make sure that trabeculum is being removed, and then doing a PI, a broad-based PI is good enough. And then you can put 3 sutures, one at the apex and 2 at the base with 10O nylon. The basal sutures can be releasable depending upon the type of the case. And with the 10O nylon Vicryl sutures, one can tuck the 2 sides of the sclera, and it does not give any leak. It can be done in any variety. I have shown you the open angle glaucoma, but it can be done in an open and closed angle glaucoma too. And if one can want to use in Palma IOL, which we nowadays rarely use it, so we can definitely extend the tunnel to the extent of 5.5 to 6 millimeter to accommodate the optics very well. And it doesn't leak, and it gives a perfect result. But nowadays, because of the availability of such a good lenses, we rarely use such things. But definitely one can use. This is my video from a charitable institute where we used to have a lot of glaucoma and cataract in a charitable wing. So rest of the surgery remains the same, putting that inner window and then PI and 3 sutures. If somebody wants to use in mitomycin C, definitely one can use a mitomycin C sponges soaked in 0.02 milligram of mitomycin C. The sponge count can vary from 1 to 5 depending upon the size and the size of the fornix cut conjunctiva or the size of sponges. I usually put 3 to 5 sponges depending upon the location, but I definitely put 1 sponge below the scleral flap, and then I keep it for 2 minutes, and after 2 minutes try to remove all sponges by count, and then giving a thorough wash. But make sure that that anterior chamber is not being opened up from the tunnel or from the side port. So it is to be done before making an incision. Same, so it works very well when you do a mitomycin C in cases like some neovascular glaucoma cases or any other cases which are very high refractive cases. It can be done in ICE syndrome with good results. I have done 4 or 5 patients with 10 years follow-up, and they are doing good with single-site phacotrabeculectomy. It can be done in secondary variety of glaucoma also. This is a patient with pseudo-exfoliation and very dense glaucoma with posterior synecdoche. It can be done in brown cataract. Can use Kelly sponge like this, or it can be used post-vitrectomy cases where there is a coexistence of glaucoma and cataract. Post-traumatic cataract because of the coexisting glaucoma and cataract, and even in one-eyed patient with very dense non-dilating pupil after sphincterotomies you can do. But one thing we have to be very careful that there should not be a vitreous loss, because all the purpose will be defeated, and once you have a vitreous loss you can do a vitrectomy. Post-operative management remains the same, but cyclopentolate is one which has to be given, and this patient requires a very frequent follow-up with good IOP monitoring, and watch for steroid responders because glaucoma can coexist, and they have astigmatism in the beginning, so don't worry, it will settle down in 4 to 6 weeks time. And now you establish the newer baseline IOP and fields, and then explain the long-term follow-up to such patients. Advantage is that you are tackling both the situations together, which is good for elderly people, and it is very comfortable because there is a single visit to the operation theater with a minimum trauma with lesser follow-up. It is cost effective, very well accepted by patients. It will give you an early rehabilitation because the patient's 2 surgeries will be taken care at one site, and it will save the time also for the surgeon because surgeon doesn't need to change the position, and it can be finished up with sitting at 12 o'clock and do 10-minute surgery. But nowadays, because we all surgeons doing a corneal tunnel sitting on a temporal site, so we can do a twin site also. It's surgeon's preference, and it is similar to any cataract surgery. Those who are trained in scleral tunnel can comfortably do it, and it is simple trabeculectomy. We can use we can have a good results which are comparable. Sometimes it gives even better results, give better sight for another trabeculectomy if it is needed in future. But the disadvantage is that it is giving you an excessive manipulation. So you have to be very careful. You have to be very skillful and very regular in the follow-up to reduce the inflammation, hyphema, and the risk of endophthalmitis, and long-term follow-up is equal. So to conclude, the phacotrabeculectomy is considered very safe for coexisting glaucoma and cataract patients. It eliminates the two invasive procedures and can simultaneously control the intraocular pressure as well as the visual outcome is good. However, careful selection is important for the maximum benefit of patients. Thank you very much for listening and giving me this opportunity.
Thank you, Dr. Vinita, for the very insightful talks. Any comments or from the panelists? Any questions you'd like to ask or give any comments, please?
Thank you, Vinita. It's a beautiful talk. I just wanted to say, when will you do twin side and when will you do single side?
Sir, I am in a favor of single site, but then I will do twin site when the conjunctiva is not healthy on a superior site, or when it is being post-vitrectomized eyes or post-buccal eyes where I don't have much of space. Then I will prefer only single site. I will not do twin site.
Okay. Very nicely covered.
Very nice.
Thank you, sir.
And the most important type, message goes out is respect of conjunctiva, madam. That's,
thank you, sir.
Yeah, most of the anterior and posterior segments surgeons, they never do that.
Yes, but then glaucoma surgeons definitely think of conjunctiva first.
Conjunctiva is a very precious structure for them.
Sure, sir.
That's a very nice
and
message.
I just preserve the conjunctiva for second trabeculectomy if one fails. So that is why I prefer single side, not giving two sides.
We can understand.
Don't you find it
pleasure listening to you, madam?
One question, don't you find it difficult to do superior phacoemulsification? Now we are, quite comfortable, rather more comfortable with temporal phacoemulsification procedure.
Anyway, you have to come at 12 o'clock to do the trabeculectomy, and then same way you have to remove the conjunctiva and shift towards the fornix and make a fornix-based conjunctival flap. So it becomes too cumbersome that sitting temporally, doing a clear corneal, then coming superiorly at 12 o'clock, doing exactly the same procedure of trabeculectomy. So why not to complete phaco from same trabeculectomy?
It's less time consuming too.
Yes.
Yeah. Very valid point.
Very well.
Thank you so very much. And let's move on to the next topic by none other than one of the doyens from India in phacoemulsification surgery, Dr. Mohan sir. He will be talking to us phacoemulsification and combined with various Vitreo Retinal surgeries. How to perfect the phacoemulsification.
Share my screen?
Yes, sir. Please share your screen.
Share my screen. You able to see my screen?
Yes, it's visible, sir.
Yes, sir.
Thank you very much, Manoj, and also the AIOS for the wonderful opportunity. I'm going to talk to you on the next few minutes about perfecting phacoemulsification when combined with vitrectomy, and probably in vitrectomized eyes as well, because Gajendra Chawla is also talking on the similar topic. I thought I'll modify my talk a little bit. As you know, past planar vitrectomy commonly performed procedure. Incidence of cataract is about 70% in 2 years. Unique challenges of cataract in post-PPV eyes. Risk of intraoperative and postoperative complications. Dense nuclear cataracts, PSC cataracts. Lack of posterior support makes rexis difficult. Zonular weakness, PC tear. Removal of the nucleus, epinucleus, cortex complicated because of lack of the vitreous support. Fluctuations in the anterior chamber and the posterior chamber as well. Iris trauma, choroidal hemorrhage, nucleus drop, and all these complications. You name the complication, it is there in a vitrectomized eye as well. So in PPV changes the structure of the eye. So biometry, optical biometry, more accurate immersion, ultrasound A scan, B scan, or UBM, you can do, assessing the need for the cataract surgery, preparing the possible complications. Informed consent is very, very important. The silicone oil, as you know, attenuates the sound velocity and axial length of fellow eyes in ideal choice in calculating the IOL power in oil-filled eye. Nowadays, you have the IOL master and the lens start, which gives the silicone mode. So you get the silicone oil thing. Actually, silicone oil acts like a minus lens. So we should add about +3 to +5 diopters to the hemetropic power. And IOL master lens start, these are the optical biometry. I'm sure everybody is having this nowadays. And it has become a gold standard as far as the IOL power calculator is concerned. Intraoperative protocols, please eliminate hydrodissection or be careful in not doing hydrodissection, less vigorous nucleus manipulation, liberal use of dispersive OVD. I don't have any financial interest. Viscoat is probably the way to go. Clear corneal incision is the way to go. Difficult capsular is difficult due to lack of the posterior support. Poor red reflex, sometimes you can have vitreous hemorrhage. Post-vitrectomized eyes also sometimes you can have vitreous hemorrhage. The red glow is not as good as in a normal eye. Trypan blue may be used. Only thing is, if you use a trypan blue, don't use it under air and use a little bit of it. Don't keep it for a long time. Trypan blue, keep it for a long time. What happens is trypan blue goes inside and produces a blue glow. Instead of red glow, you'll get a blue glow. You can see these sort of cataracts are very, very common. Post-vitrectomy, calcified anterior capsule, you can see the zonule. As soon as you make the rexus itself, you can see the lens is moving around, the subluxation of the lens, the sphecodonosis, which is not very uncommon. And you can see here that I'm using the capsular rexus forceps to make sure that the central fibrotic element is taken care of as well. Again, you can see these sort of cataracts, post-silicone oil patients, the post-vitrectomy patients, very, very fibrotic anterior capsule, calcified anterior capsule. Sometimes you might have to use the vitreous scissors or even the cutter to make sure that you get the capsular rexus right in these patients. Poor red reflex, I'm sure Gajendra is also going to talk about is another major important thing. Use the trypan blue very, very optimally or judicially. Don't use it with make sure that because otherwise it's a relatively blind technique. This is a relatively softer cataract. I just popped it up once I did a capsular rexus and did the phacoemulsification. Slow and gentle pre-existing PCR. Please understand these are all vitrectomized eyes. Sometimes number of multiple injections of Avastin Lucentis is given. Be careful of these patients. This is again another patient who had number of injections of Lucentis and dense brown cataract. As soon as my assistant put heavy molecular weight viscoelastic on the cornea, I can see the nucleus disappearing into the anterior into the vitreous cavity. So this is one of the major problems. Be very, very careful in hydrodissection because there can be a pre-existing PC tear because of the vitrectomy, the lens touch could have been there, or because of the number of injections which are given. Pure pupillary dilatation rings and hooks. You can use Mulligan ring, or you can use the hooks which are commonly used as hooks, or the Mulligan ring. So there, and it's produce a less deformity. You can see the BX ring, which is there, which is made by Bhattacharjee, which works very well in these conditions, and it comes through the side port as well. Again, you can see here, this is again a complicated cataract, and combined with the vitrectomy, you can see here how I'm removing the membrane and putting the iris hooks and dilating the pupil as well. So small pupils, sometimes if we don't have anything, you can even stretch the pupil, but I would not suggest this because it pretty makes the pupil very, very atonic. You can see this is a pupil stretching. Don't do it in the axis of the incision. That is another important point which you have to remember. Deep and unstable anterior chamber, reduce the bottle light. ARIS is acute intraoperative rock hard eye syndrome, managed by halting the irrigation, putting external pressure on the incision to stop leakage. Anterior pressure counteracts the posterior pressure. This is one of the most important because zonules are weak, and the fluid can go behind and push the posterior capsule up. And this is called the ARIS syndrome, which is an infusion deviation syndrome, are not uncommon, especially people who are when they're operating on high myopes with vitrectomized eyes as well, because the zonules are weak and the fluid can go into the vitreous and start pushing the posterior capsule up. Again, you can see there's a fluctuation in the anterior chamber as well as the posterior chamber. You can see here, just like the eye fist syndrome, you can see here, as soon as this is because they have the fluid misdirection syndrome pushing the iris up, and as soon as they go inside, the pupil again dilates. And one of the common problems we see vitrectomy because of the lack of the posterior support which is there. Nucleus dismantling vertical chop techniques, less stress on the zonules and the anterior capsule, and PC plaque remove always, because it's very difficult to do YAG laser in these patients because it's a very dense fibrotic capsule, especially post silicone oil. There can be a calcified posterior capsule plaque, which is very, very difficult unless you remove this thing. This is just to show you that I make a rhexis. You can see here, just fairly brown cataract. It's very dense cataract, very common post vitrectomy, post oil, and this is very, very common, especially in the older age group. And you can see here how I'm doing the direct chop or the vertical chop technique using the sharp chopper. And just to show you this, this one, another patient with the vitreous hemorrhage, I think, yeah, again, rhexis. The problem is the rhexis, you need to go sometimes, you need to have a very good microscope. If you have microscopes like the Leica, the Lumira, which is very, very good, the top end microscope, that's got a fantastic retro glow or the retro illumination, which is very, very good. And even in dense cataracts and even white cataracts, you can go ahead with doing the rhexis without any problem at all. So this is a way the perfecting phacoemulsification. Sometimes you can have sinic A, and you need to open up the sinic A and make sure that you can see this is a patient who had a phaco traumatic cataract with traumatic vitreous hemorrhage as well. You can see here how I'm trying to do the open up the synovial and trying to do the rhexis, and this is a very mature cataract followed by waiting. Zonal weakness, pre-existing posterior capsule tear, and just to show you a subluxated cataract traumatic again combined with the vitrectomy, and just to show you that I'm doing this thing here because of lack of time, just to show you this cataract. Again, I will take only 1 minute more. You can see the lens is moving there. You can see I'm doing a rhexis and supporting the capsule, the bag with the capsular hooks, and then going ahead with the phacoemulsification and making sure that the bag is rinsing, and halfway through I do insert a CTR as well. Dense posterior capsular plaques, polishing the posterior capsule, removal, posterior capsular rhexis, ND YAG laser. Just to show you this one, this is a dense posterior polar plaque there. I do what is called a plaquectomy. You can see here, this is very difficult to YAG these. And this is an young patient who had a fairly dense posterior vitrectomy. You can see here how I'm trying to remove the plaque. Sometimes I use a bimanual technique. You can see that I'm using a bimanual technique to remove this. This is called the plaquectomy. You can just remove that and go ahead and implant a lens in this in this patient as well. So IOL options, always prefer an hydrophobic IOL in the bag, 3-piece IOL in the sulcus with an optic capture. And this is an optic capture. You can see if we put an optic, put the lens in the sulcus. Always make sure that you put an optic capture, capture the lens. Very, very important to capture the lens and look for the ovalization of the anterior capsule when you capture the optic with the haptic in the sulcus and the optic in the bag. And this prevents the UGH syndrome and make sure the lens is very stable. Topical steroids, anti-glaucoma medication, NSAIDs, retinal evaluation, YAG cap after 3 months if necessary. Phaco and PUPIL device, higher risk, good preoperative assessment is necessary. Intraoperative protocols, very religiously you have to follow. Postoperative protocols also you have to follow. Good visual outcome in 90% of the patients, provided you follow all the protocols very, very, very strictly. Thank you very much, Manoj and AIOC for the wonderful opportunity.
Thank you, sir, for the wonderful presentation as always. What I request is we'll have continuation of all the talks now because all are combined cataract and the retinal procedures, and then we will have a discussion.
Absolutely.
So invite Dr. Gajendra Chawla, sir, for his talk on phacoemulsification with vitrectomy, please. Dr. Gajendra, sir.
Yes. I'm sharing my.
Wonderful talk, Mohan Rajan, sir, as always.
Thank you, Manoj.
It's a pleasure learning with you, every single day.
Thanks a lot.
He's a champion of champions. And he has shown so many variety of cases, and this can all happen in post-vitrectomized eyes and all these things. Wonderful. Tremendous experience.
Yes, sir.
Thank you, Purindra.
Yes.
Gajendra, we are waiting for you.
Can you see my slide, sir?
We are not able to see
No,
a
we're
screen.
not
sir.
able to see.
Share it.
If not, we can go to the next talk and come back to Gajendra. Manoj.
Yes, sir.
Is it visible now?
Fine.
Yeah, now it's visible.
Excellent, sir.
Please go ahead.
Yeah. Thank you, Manoj, Dr. Manoj, and AIOS. We are talking about the combined procedures in this session. So my talk is on combined phacotrabeculectomy, how we can achieve good results. As you know, result of vitrectomy is depend on how better, how good, or how clear we can visualize our surgical field during the surgery, and how we can perceive the focus. So clarity of media is always it's the basic and essential requirement for the better outcome. Vitreoretinal conditions are often associated with cataracts, so managing it simultaneously is always remains concern for the vitreoretinal surgeon. When we are performing a surgery, vitreoretinal surgery, we come across around 3 situations. The first situation is when cataract is visually significant. In that situation, decision is very straightforward and very easy. We have to go for a combined surgery. There is a second situation when lens is clear and it is a younger age group. Here, our aim is to preserve the crystalline lens so that which is very crucial to prevent accommodation and thus the better visual development of the younger age group patient. But when we are dealing with a patient who is phakic in the older age group, then performing vitrectomy alone in phakic older vision is a gray zone. We can combine or we can have a separate 2-stage surgery. If we go to the literature, review the literature, the incidence of lens touch during the vitrectomy varies between 4 to 9% in the different reports. And rate of cataract progression is also increases after vitrectomy, especially when we are using the silicone as a tamponade. Almost 60 to 70% patients require cataract surgery within first year of vitrectomy and almost 80% in the next 2 years. So in these situations, our approach is phacotrabeculectomy combined. This one video I'm showing of combined surgery which we do. It's about 58 to 60-year-old diabetic patient having a significant cataract. So as usual, we are going for a routine phaco, side port, clear corneal incision, phacos after using refined blue, going for a routine phaco and a implant, a foldable implant, with all precautions which Dr. Mohan has already mentioned about. So after completing our phaco, we are going for a vitreous surgery. And this particular case, we have used 25H vitrectomy, 3-port standard vitrectomy, doing a vitreous surgery, removing all vitreous, possible vitreous. When there was a, we have used Transilon to identify the posterior highlight and inducing the PVD. And after we are completing our vitreous surgery, removing all traction here and there, removing all hemorrhages from the retina, doing the basic scene as possible, and after this we are doing a endo laser all throughout, and then fluid gas exchange. We are removing all this trocar, but in when I was removing the last trocar, there was wood leak, and we do not hesitate to put a suture also. The advantage of combined phaco surgery is there is no risk of lens touch because we have already removed it. It is easy to remove the peripheral vitreous. We can have a very good shaving of the vitreous base, and we can approach the peripheral region, so we can see all lesions, and so it is very easy, and we can give a better treatment to all this lesion. When we are, if we are working on a posterior pole, having ERM or island filling, we have to do, then having a clear media give you a better visualization. Single surgery is a more economical than 2-step surgery. It is having a shorter post-operative care, less hospital visit, faster visual rehabilitation. In 2-step surgery, patient is exposed twice for the risk of intraoperative and post-operative complications. Then there is a psychological trauma of surgery for more sequential approach. But there are certain challenges of this combined procedure. In following slides, I will show the challenges and how to manage and these challenges. The solution is also being will be discussed. The performing cataract surgery, I'm not going to detail because Dr. Mohan Rajan has already shown the beautiful videos. There is one common problem was our first problem is if we doing this combined surgeries would leak or hypotony when we are starting our vitreous surgery or we are placing our trocars. To prevent this hypotony, we can place trocar before the infusion, trocar for infusion before starting the phaco. We can leave some amount of viscoelastic in anterior chamber after completing our phaco, and we can close our main wound by 10-0 nylon so that wound will not be leaked. Performing cataracts in absence of red glow, as Dr. Mohan Rajan says, yes, it is a difficult situation when we are having a dense vitreous hemorrhage. It is difficult to see the red glow. So, as he suggested, use dye for a better visualization. And as Dr. Bhasin sir has shown, that using the chandelier light from inferior temporal sclerotomy, one can see a good red glow to perform our capsular axis. During surgery, we can come across the intraoperative meiosis. To prevent this meiosis, we should, the phaco surgeon, whether it's the same surgeon or it's a two surgeon, depend on the setup, the iris manipulation should be minimized. We can use intracameral hydrolysis or we can dissolve the hydrolysis in infusion if required. There is some prolapse of UVL tissue from the phaco incision because of the increase in intravitreal pressure. So, if after completing our phaco, we do a good hydration, we can prevent such UVL tissue prolapse. And as I suggested earlier, also we can apply a 10-0 nylon suture to the phaco main incision. During surgery, because of the longer duration of surgery, we might have a poor visualization because of the corneal edema. So we have to prevent this corneal edema. We can use a intraocular infusion pressure on a lower side. We can use viscoelastic on cornea on a regular interval, and if required, one can scrape the corneal epithelium to complete the vitreous surgery. Inaccurate IOL calculation is another problem one can face, especially when we are dealing with cataract with macula of detachment. So, as Dr. Mohan Rajan has suggested, we should use IOL master or optical biometry instead of the ultrasound biometry to minimize the risk of postoperative refractive surprises, and should avoid the hydrophilic and silicon IOL to prevent the PCOs. Sometimes when we are performing the surgery, that temporary, whether it is a gaze or simple air or a gaze or silicone oil comes into the anterior chamber and that causes the trouble in performing the surgery. To prevent this, we can leave the viscoelastic in anterior chamber to prevent this entry of temporary from the zone during the vitreous surgery, which can be this viscoelastic can be removed at the end of the surgery. There is a risk of anterior displacement of IOL because when you are using the silicone ion or expansion gas, that can cause the pressure and there can be anterior displacement of IOL. To prevent this, after postoperatively, we ask patient to lie down with the face down position, and when we are performing the phaco, we should have a very small CCC. There is an increased risk of postoperative inflammation because we are having a longer duration of surgery. To prevent this, we have to use more intensive use of steroid and for longer duration. One can give a conjunctival or subtenon injection at the end of the surgery. Some post-op hypotony is also associated with this combined surgery. So to prevent that, one should not hesitate to apply suture to the sclerotomy site. To conclude, although the unique challenges exist in terms of planning and execution of the combined surgery, which can be generally overcome with the appropriate modification, favorable outcome can be achieved with combined phacotrabeculectomy procedures. Thank you for patience hearing. Thank you.
Thank you so very much, Gajendra sir, for the wonderful presentation. It's always a pleasure listening to you and to your talks. Next, let's call upon Dr. Piyush Bansal, young dynamic surgeon from Pune. He will be talking about challenges in peeling the vitreoretinal membranes in combined surgery. Piyush, you are there?
Yes, sir. Give me a second, sir. Thank you so much for the lovely, kind introduction, sir. And sir, is my slide visible, sir?
All visible. The stage is yours.
Okay.
Go ahead.
Okay. Thank you so much, Manoj Khatri, sir, for extending a kind invitation to me and be a part of this excellent instruction course. It's a dream to be with such stalwarts in the same course, learn from them, and be able to present my work as well. It was a wonderful presentation by Dr. Chawla, so most of the points have been brought out. In addition to that, I have another point which probably will take up in the discussion. So I'll be talking about challenges in peeling vitreoretinal membranes in combined surgery. Now, as Dr. Chawla said, that combined surgery offers many advantages, including whether it is financial viability or reduced post-operative visits, ease of during vitreoretinal surgery as well. However, it comes with its own set of challenges. And these challenges could be so many fold as discussed by sir. I'll be sticking only to a few, which is peeling during peeling of membrane. So this is post cataract removal in this particular case. This was a diabetic patient who also required an ILM peeling since he did not respond to multiple injections, and the edema just wouldn't settle down. So post-cataract surgery, it was a good idea to do ILM peeling in such a situation. So after doing a good vitrectomy and peeling the posterior hyaloid, now what you can see over here is that the visualization definitely becomes difficult in such situations, no matter how good your phacoemulsification is. So it's important to quickly finish your phacoemulsification as soon as possible and make sure that the edema is comparatively, the corneal edema does not set in before you start your vitreous surgery. Yes, this is especially important when you're working close to the macula. So now you can see that the ILM peeling over here it's not as clear as when you're going through a patient who has already had surgery done in previously and the inflammation has settled down. There's no corneal edema. So this is a definite challenge in these sort of situations. Another indication where we commonly do combined surgery is patients who have an epiretinal membrane along with cataract. Doing surgery over here and peeling the epiretinal membrane becomes extremely difficult if there is any hello. It becomes extremely difficult when there is any difficulty in visualization. So another trick over here is to use the help of brilliant blue G while peeling the epiretinal membrane post cataract surgery. As you can see, the visualization was not very great over here. But after you stain with the brilliant blue G using a negative staining, you can see over here that. So what you can see over here is that the epiretinal membrane delineates itself quite nicely once the ILM stains with brilliant blue G around it, and then you can proceed with peeling of the epiretinal membrane, whether in toto or whether you remove it in piecemeal. That does not really affect the final outcome. But what is important is to remove the epiretinal membrane as much as possible. Following removal of this epiretinal membrane, you can definitely go ahead and remove the ILM peeling, which ensures that there is no any further traction that is remaining. And subsequent to the ILM removal, since the visualization was not that great, what can also be done is as against just using brilliant blue G to stain directly under fluid, you can fill it up with air and then use brilliant blue G. So that ensures that the staining is better. You don't need to keep it for a long time. Just a minute or two is more than sufficient. And then this is to show that we use the stain again to make sure that we have removed all the ILM around up to the macula, up to the arcades, so that there's no further chance of traction. Macular holes are by far the most common places where we do combined surgery again. Post following phacoemulsification, we peel the ILM. Now it's important to note over here that visualization can be difficult. So in such a situation, you can always switch between different lenses from either a contact lens to a wide angle visualization system to increase and enhance your visualization. You use brilliant blue G instead of staining, instead of peeling directly. Also, what's important is that instead of just trying to aim like a capsulorhexis or a maculorhexis every single time, you can also have multiple grasps of the ILM and make sure that undue pressure is not put on the retina, because the visualization can be compromised in such a situation. So the eventual outcome is definitely going to be the same. So unnecessary traction should not be put on the retina. This is of a video of a large macular hole where an inverted flap was being planned. Now, the point I would like to bring out over here is, if you see carefully over here, you'll be able to see some hemorrhages over here. So when visualization can be a problem, we can end up grasping the retina and causing inadvertent breaks if you're not careful. So it's advisable that while peeling, if you feel that you've grasped it too hard, or if you've caused a retinal hemorrhage, it's better to start off at another site instead of unnecessarily struggling and trying to peel off from there itself. You'll end up injuring the retina rather than having a good outcome. Now, this particular video I have added because it's essentially, the background is that the patient had a macular hole with a very high myopic eye, had a staphyloma. You can see the contrast is very the visualization is extremely bad. Apart from that, you can see that the hemorrhages are there. Now, the hemorrhages, I caused these hemorrhages because I literally struggled to peel the ILM, which was very patchy despite staining twice. And it was extremely adherent. So while trying to peel them with an ILM forceps, I was more traumatic to the retina. So essentially, I had no other option. And as a final attempt, what I tried to do was use the finesse loop to try to scrape off. I mean, this is not the use that a finesse loop has, but I try to scrape off whatever ILM I can from as much around the macula as possible. Fortunately, the patient had a good visual outcome. You can see the amount of pressure that's required in such a situation. Now, in many times we come across patients with macular hole RDs. Now, some of the complications that can happen over here, even though rarely, is that you can have PFCL, which we use to flatten keep the retina flat while we peel the ILM, entering the subconjunctival space. Entering the subconjunctival space either during insertion or during removal of the PFCL. So this is just another way that the case can be approached. If you have a decent visualization, if I didn't have a good visualization, probably it's not a good idea to do it. But if you have good visualization, then what one can do is peel in. What one can do is peel without the help of PFCL in order to avoid any further complications than are already there. So after peeling the ILM, one just has to be a little more careful because it's a mobile retina and one can end up creating another break over there. So following peeling the ILM, you can see that it will be tucked over here into the macular hole, since it's a pretty large hole. And following this, it's also important that in such situations, you make a separate retinotomy site, what you'll be able to see over here, and never try to drain fluid from the macular hole itself. A patient with in diabetics often have their own unique challenges, and while peeling the tractional membranes and the proliferative tractional areas, it's very important that yes, I'm almost done. So what you can see over here is after peeling the tractional membrane, the ILM peeling is initiated, and you can see that the retina is quite boggy. It's actually folded upon itself. So even after removing of the tractional membranes, the retina is definitely going to take some amount of time to flatten out. And while taking this opportunity to peel the ILM, it's very important to be careful and be extremely gentle and have less evasive maneuvers while peeling the internal limiting membrane. So another patient where after cataract surgery, now visualization was fairly good, however, in this case, and after peeling off the tractional membrane, we can use bimanual techniques of surgery over here to make difficult dissections comparatively easier and try to achieve as much of traction removal, membrane removal as possible. You can see the retina over here, the macula is so boggy, and one has to be very slow and very gentle in peeling the internal limiting membrane in such situations, because as it is, we are faced with we are doing a combined surgery. So in such a situation, you have to be very, very gentle. The last video that I'll be showing is of a patient who had a traumatic. Yes, sir. It's my last video. So this patient had a traumatic retinal detachment. The cataract wasn't much, so I went in and initiated the vitrectomy. However, the visualization wasn't that great, so I decided to do a vitrectomy as well, so a lensectomy as well. Post lensectomy, the visualization definitely improved. However, there was still certain amount of corneal edema. We do have to deal with such situations also, wherein the visualization is not going to be at par, and we have to do with what we have. So in such a situation, again, what you're seeing over here is there are staph holes, and peeling has to be peeling being done, removal of all scar tissue, and releasing these staph holes as much as possible. Another aspect over here is after releasing that, you see even the macula is folded upon itself. So it's important to be extremely gentle in your maneuvers and make sure that you don't cause any inadvertent retinal breaks in an already compromised retina. Following this, I always put in an IOL in any combined surgery. An IOL is put and the surgery is completed. So I thank you very much. I've already overshot. Thank you, Dr. Manoj, for bearing with my overshooting of the time. Thank you very much for your patient hearing.
No problem, Piyush. Very nice videos and eloquently discussed all the final nuances of VR surgeries. It's always pleasure, learning and listening to you, I will say. Next,
brilliant video, sir. Piyush.
Yeah.
Thank you so much, sir.
I've not seen videos like this. Really fantastic videos. Quality of the videos. Yeah. Very good.
Thank you so much.
So next, it's a pleasure to call upon Dr. Rajiv Raman sir. Last but not the least, the person who first taught me the importance of, though he's going to talk on a topic called a silicone oil removal, but he just, taught me the importance. The person who injects silicone oil should always remove the silicone oil. The words are still fresh in my memory, sir. So
sure, sir.
Let's learn from you on the same topic again.
Thanks, Manoj. Thanks for putting up such a nice program. It's a good learning. Each speaker gave some very good tips, and definitely, 1 minute, I have to remove this thing at the top. 1 minute.
Take your time. Stage is all yours, sir.
Yeah. So next couple of minutes, I'll be sharing some views on phacoemulsification with silicone oil removal. One of the procedure which is very, very commonly done, and especially I would agree with Vitreo Retinal. 1 minute. Yeah, surgeons will agree this is one of the very important very important surgery which is done very commonly in both via anterior segment and where there is combined anterior and posterior segment surgeon. So the primary aim of surgery of a phaco with a SOR, one must realize why you are doing. If you have done a good vitreoretinal work and the patient has got a good visual potential, it is for the visual benefit. Many times it is not, we are not sure about the visual benefit, but we are unable to evaluate the retina post VR surgery. Cataract has increased, as previous talks it has told, nearly 60% of them, the cataract progression happens. However, in majority of cases where the cataract is significant, cataract surgery is usually combined with a primary vitreoretinal procedure. We need to think some pre-operative considerations we should think before we plan for a phaco and a silicone oil removal. Low intraocular pressure, you tend to avoid doing a SOR. High pressure, you'd like your glaucoma colleagues or probably plan for a combined, as Dr. Vinita Ramnani had told, combined procedure with a TRAB 2. Ideal situation, a normal IOP with a cataract and silicone oil in situ, you plan for this combined procedure. Age of patient is important. You need to really think that when you are planning and what are the long-term expectations of this procedure. You need to definitely look into the visual potential of that eye, because you have done the primary VR surgery, you know how much vision that person may recover. And based on that, you plan. Also the status of contralateral eye, and definitely the PC status, whether it is intact or breached. You want to go ahead looking at his past history, whether there was any previous recurrence after SOR. Many a times patient comes with a redetachment, you have again put a oil, and that's the time you're planning its removal. You want to keep the oil for a little longer period. Look into your old surgical notes, whether you have done a complete base excision or not. Because if you're not done, that vitreous will be there, and while definitely there is a more chance of recurrent RD. Whether laser was done, whether there was a 360-degree laser you had done or done a localized laser, some of these cases you tend to look more carefully the periphery. You may need to do more laser before you plan for a procedure. Any complication which happened in the primary retinal surgery, like a lens touch, and definitely the present retinal findings, whether there is any epiretinal membrane, any tractional element you'd like to tackle when doing this combined procedure of silicone oil removal and cataract. It's already been explained. The IOL power calculation definitely is a little challenging situation, because we know in silicone oil filled eye, the sound travels more slowly. There are various forms.
I think we lost you in between, sir.
Yes, I think there's some connectivity issue at his end.
Rajiv, sir, you are there?
No, sir, I think
It is
might
from the
join
back
back.
end. It is from the back end office or from Dr. Rajiv's?
No, it's from their side, sir. He's back. He's back.
Yeah.
Sorry, I don't know why it got disconnected.
No problem. Take your time.
Sure. So I was on this slide when it went, I think, correct?
Yeah, yes, correct. This slide.
So whether to do a cataract surgery or SOR first. So better to do a SOR once you have a visualization. Without visualization, don't attempt to remove the oil. And it's better to secure an infusion cannula before your cataract surgery, because you have a chance to manipulate the intraocular pressure if needed. Definitely, if there is no view, you do a cataract first. And whenever you are doing a Vitreo Retinal procedure or SOR in a along with cataract, use a new trocar and cannula. Because many times if you're using it for second, third time, the globe will indent, the IOL, the AC will collapse. So just make it sure you use a new trocar. Again, also depends on who is doing the cataract. In an institution setting, sometimes you have an anterior segment surgeon doing, and he prefers to do a cataract first. So that is done first. Again, the choice whether to use a 4 millimeter infusion cannula or a 6 millimeter, a longer cannula. If a patient had previous history of multiple surgeries, better to use a 6 mm cannula. If there is poor visualization, you are not able to visualize the tip of the cannula, again use a longer one. And if the primary indication of the vitreous surgery was an inflammatory pathology, again, I tend to use a 6 mm cannula while removing the oil. Again, a challenge of the first step is handling the anterior chamber emulsified oil, or sometimes even the vitreous emulsified oil. So in anterior chamber, always remove this AC emulsified oil first, do a good AC wash. Regarding the vitreous emulsified oil, you may tend to do a repeated partial FGs. That will help to remove to the emulsified oil to some extent. But even after doing multiple FGs, sometimes you may have some oil which is remaining, the emulsified oil. And these are the cases, look for these perisilicon oil membranes. These are very thin fibrous proliferation. Below that, there will be a lot of emulsified oil. And these membranes need to be removed. So you need to make the third port and go ahead removing this, and then removing these emulsified oil. Regarding cataract surgery, already a lot has been spoken. Use a heavy viscoelastic. Definitely you don't want any leak. As was told, the PC is thicker, it is more leathery. Again, the anterior chamber, the rhexis is very much difficult. Aim for a relatively small rhexis to prevent popping up of the IOL if there are some manipulations you are doing in the posterior chamber. Anterior capsule you may use, as Dr. Mohan Rajan very nicely showed, you may need to use a forceps. Sometimes even you may need a scissor. You may need to use hooks in case of synechis. And if it's a uveitic eye, you tend to give a corticosteroid cover before planning the procedure. Any of the procedure has got its own complications, and even this procedure has a complication. The most common is a recurrent retinal detachment. So this is something you need to tell all your patients, that whenever you are removing the oil, it's about 15 to 20% risk of recurrent retinal detachment. And especially the risk factors for recurrent RD are those who had already previous recurrences, poor visual acuity, incomplete removal of the vitreous base during prior vitrectomies, or absence of belt buckle, especially in a case where you had severe PVR. The rate of recurrent detachment, somehow the current evidence suggests it is not dependent on technique of removal of SOR, silicone oil, or on the duration. It's not like you keep the oil for a longer time, the recurrence will be less. Emulsification, as I had told, there are many factors which are responsible for emulsification. In the initial surgery, a more eventful surgery, lot of bleeding inside. You have serum, fibrin, fibrinogen, all are intrinsic surfactants. They cause emulsification. Again, external ones like sterilization detergents on the vitrectomy tubing or cutter, that can cause a longer duration of silicone oil fill. Less complete fill is the most common cause of having more emulsification, or if you have used a PF4 during your surgery, and that prompts for early SOR. And even after SOR, you may have some emulsified oil which is still remaining, and that sometimes can adhere to the IOL, especially if you are using a silicone IOL. And these are very problematic. They cause a lot of visual disturbance. Just 2 minutes more, visual distortion, glare, micropsia. And there is no way you can remove these ones, and they need the IOL exchange. Silicone oil keratopathy can even occur after silicone oil removal if you have left with these emulsified oils which comes to the anterior chamber, and the incidence is nearly 25% in 2 years. Again, oil in AC, hypotony is an important risk factor, and reoperations. It can cause both glaucoma and hypotony, secondary glaucoma, especially in aphakic eyes, diabetic vitrectomies, pre-existing glaucoma. There are many mechanisms for this. And especially when you are doing SOR in cases of a complex retinal detachment case, or a trauma, inflammatory, when you have done a large relaxing retinotomy, or a case of a giant retinal tear, you may get a hypotony. You must keep that in mind. So to conclude, a good understanding on the aim of doing the procedure. It's not like every case like phaco IOL SOR is needed. Understanding why you want to combine both the procedure, keeping in mind the pre-operative considerations which I have told, the right technique, and keeping a watch on complication and managing them timely would have a good outcome and a happy patient. Thank you very much.
Beautiful talk.
Thank you so much, sir, for the wonderful talk. As I said, he is the person who told us, the guy who injects silicone oil should do a silicone oil removal as well. He only knows what is what has gone into as a complication as well into the eye. Thank you so much, sir. So we have 5 minutes for discussion, and before we start question answer session, I have about 8 questions on my chat box. Let me ask all the panelists for one pearl which they want to give it to the audience, starting from Dr. Purendra, sir. Can you give one pearl which you like to give it to the audience, sir, based on your talk, combining cataract with corneal problems? Dr. Purendra, sir.
Yeah, I think most important is ocular surface checkup and examination. That should not be overlooked, and that should be done before taking any patient for the cataract surgery.
Okay, one question for you from the audience is removing epithelium helps in aiding during the phacoemulsification procedure? When you have a corneal opacity, you want to remove the epithelium. Is it advisable?
No, I don't do. I have not done, and I don't do. There is no recommendation.
Respecting the corneal epithelium is of utmost importance, should not be removed unless and until it's an iatrogenic.
Yeah.
Okay, Dr. Vinita, madam, pearls from you to the audience, take home message.
Sir, until unless you are not confirmed of glaucoma severity and cataract type, and if you are not confident, please don't do combined surgery. It is better to do separate surgeries.
Okay, the question to you, a lot of questions have come to you, madam, about 5 to 6. The most important ones I'm taking. First question is, do you change anti-glaucoma medications after combined surgeries? If yes, which one you will prefer?
Dorzolamide is the preferred medicine for post-op patients.
Okay, any medications to be avoided for blepharosis is the second question to you.
Prostaglandin analogs.
Okay, anything else?
Most likely these two.
Okay, and combined surgeries, you have a bleb leak on the post-operative day too. How will you manage it? One of the audience have asked.
I put 3 sutures. That is why the leak is not there. But if there is a leak, I will just put a pad bandage and give good cycloplegic. Wait for 2 days. If it is not resolving, put an anterior chamber air. And if it doesn't respond, then you can reassess your blab and put more sutures.
Okay, ma'am. Thank you so much. Due to paucity of time, I'm not taking the other questions.
Yeah,
Dr.
just one point I'll add for Dr. Vinita. It's a very important talk.
Please.
And one thing which you can probably take home message is, if you are anticipating a rise of IOP, like it's a traumatic eye, or you are doing a case inflammatory, or other eye has got a glaucoma, tell your retina colleagues to spare superior conjunctiva.
Yes.
It is very important. Nowadays, though we are doing small gauge, but many times if you are passing a belt buckle and cerclage, you tend to open the superior conjunctiva. It's important to tell them open paralimbal. So that, and at one time when Manoj will agree, when we didn't had a EMR, our glaucoma colleagues used to write and underline with a red pen. That is something which is an important take-home message, especially for the retina guys.
Red flag sign.
Yes. Red flag sign. So coming to Mohan Rajan sir, your turn. Take-home message, top pearl. What do you like to share to the audience?
No, the most important thing is, please understand that vitrectomized eyes is a different ball game. It's not the same thing of what is a regular phacoemulsification. Just like the pediatric cataract, everybody thinks the pediatric cataract is a miniature adult eye. It's not like that. Same way in vitrectomized eye also, a complete pre-operative assessment in following the intraoperative protocols and the post-operative protocols are very, very necessary to give good outcomes to the patient and prevent complications. This is my take-home message.
Okay, the next question to you is viscoelastic of choice in these eyes while doing capsular access.
Viscoat. Viscoat is my choice.
Viscoat is your choice.
Yes.
How will you manage runaway rhexis in these eyes?
That's what I will do. As I told you, the rhexis, it may be a little fibrotic. Sometimes you might have to use the scissors. And the fibrotic capsules, sometimes, most of the times, you cut with the scissors and try to use a capsular access forceps, and we can try to do that as well. But the one advantage of having a fibrotic capsule, it doesn't extend beyond. It's unlike the regular ones, the regular capsules, the fibrotic calcified capsules, it does not extend posteriorly. So you don't have to bother about that unless it's a very, very hard brown cataract or something like that. Even then, it's not a very major issue.
Okay, sir. Thank you. Dr. Gajendra, sir, your take-home pearl.
Actually, I will say, if there is a clear lens, maybe age of 30, 40, 50 year age old patient, don't go for a combined phaco surgery. There is a trend nowadays, all cataract should remove. I'll prefer in such situation, put a belt buckle, do a good vitrectomy. And if cataract progression is seen in the follow-up after 6 months, 1 month, 1 year, then only do a cataract surgery. Otherwise, don't do. People doing right in and out at 30, 40, okay, cataract to hona hi hai, we'll do it right now. So I'll suggest don't do in the such age. If there is a cataract, 60 plus grade 1, 2, you can definitely go for a phaco combined.
So question to you has come is, when you are deciding on belt buckle, you will like to finish the phaco first and then do belt buckle, or you put belt buckle first and do phaco?
No, I usually do belt buckle first, then phaco, and then go for it.
Okay, and the belt buckle of choice is 240 band?
Yeah, it's always 240.
240 band. Due to paucity of time, sorry, sir, I'm skipping the other questions. Piyush, your take-home pearl. A lot of questions have come for you.
So my take-home pearl would be that do not be under the pressure to do a combined surgery in the first place. Know yourself, whether you would want to do it, whether you would be comfortable. First of all, whether you are comfortable to do the phaco yourself, or if your anterior segment who's working with you, whether you're comfortable with that person operating first, and then you are being able to continue with the vitrectomy. This is especially important in patients where you are peeling membranes working close to the macula, because visualization is without a doubt the most important aspect over here. We do not want to complicate matters first.
Okay, next question to you is how you use double stain. Can you elaborate?
Dr. Manoj, let's conclude in 1 minute.
1 second, just 5 seconds. 2 more questions.
So double staining is essential.
I'll leave. I have another session.
Sure. Double stain, Piyush.
So double staining, what I meant is we don't use 2 different stains. We use a single stain. We just stain it twice. So post peeling the ILM, if you are not sure whether the entire ILM is removed, or especially in patients where you have an epiretinal membrane complicating matters, so you stain it again. Usually I don't even use air to stain the ILM, but then in such situations where it is difficult or the staining is not as evident, then I fill in air and try to stain again. So that essentially I refer by saying double staining.
Last pearl by Dr. Rajiv Raman sir, then we'll conclude.
So I would suggest, as far as technique is concerned, already people have that phaco is more challenging. The silicone oil removal is a fairly simple job. However, the decision of doing both, combined or not, should be done by a Vitreo Retinal surgeon, not by a cataract person, because he knows what is there beneath inside, and whether the nuances of all other things which I told is a decision which should be taken by a retinal surgeon.
Thank you so very much, sir, for all your pearls and wisdom. And with this, we'd like to conclude the session. I would like to thank once again all the speakers, panelists, as well as the AIOC for giving us this wonderful opportunity. See you all again next year, hopefully physically.
Thank you.
Thank you so much, Dr.
Thank
Manoj
you so much
for
Bye, Manoj,
leading
sir.
the session.
Bye, Rajiv, sir.
You were fantastic. Thank you so much, all the speakers.